something that I didn't insert into the slides. And either fortunately or unfortunately for everyone and myself, I just finished putting the slides together. I've meant to do it for forever. Tia gave me this forever ago. And I don't know, it's been difficult to breathe recently, so I finally came up for air. And now we get to do Care of the Burn Injured Child Part Deux. So I'm going to share my screen. And I called it Part Deux because, as Tia alluded to, we already did a Part 1. So this is actually Part 2. And what I wanted to focus on was all case studies. So hopefully you guys will have lots to say, and Tia's going to help me monitor the chat. But I can't see it on my end. I can just see multiple screens. Oh, I'm just actually opening chat, so I can try and keep an eye on it too. But if I neglect to do that, then Tia will keep me straight. So anyway, this is Part Deux. It sounded more exotic than Part 2, and it's called The Great Outdoors, because Tia and I went back and forth about what to do, and we figured it was almost summer, even though you wouldn't know it, this weekend. But and everybody wants to go outside, and everybody wants to do fun things, and so we decided to focus on that. I do have something to disclose. I don't have something to disclose, but I do have something to disclose. And it's the thing that I say many, many times. Burn injury is actually a cultural problem in our great country because of this right here. And these are my two children a long, long time ago, because I'm way older than I was back then when this picture was taken. But this is them in front of, it looks like 5 birthday candles. Yep, 5. So my daughter at the time was 5 years old. And, you know, usually when we have a birthday of a child, we give them this cake with a candle on it. And when they blow that candle out, they learn that they can control fire. And not only can they control fire, but they'll be rewarded for playing with it with gifts and cake. So culturally, fire is difficult to control because we don't teach people that fire isn't controllable, that we shouldn't play with fire, that we won't be rewarded for playing with it. And some of the cases that I'm about to introduce to you are actual real patient cases. And unfortunately, burn injury is lifelong. And so the reward really is lifelong injury that can really make an impact psychologically and physically on those unfortunate people that sustain it. And these are my objectives. I'm kind of a geek, and this is my amazing grandson. He's actually my favorite grandson. I'm grandmother to 5, which is crazy. So today, for the next 50-ish, 60 minutes, we're going to talk about initial evaluation essentials. So what it is that you guys need to do right on scene for the pediatric patient. We're going to talk about prioritization of medical management of those patients and identify core concepts necessary for you guys to transport them to wherever it is that you need to transport them to. And I want to introduce something new here that absolutely wasn't around in Part 1, and that's just our amazing partnership with Primary Children's. So the Burn Center and Primary Children's, as you know, are in super close location to each other. In fact, they're a walk across the bridge. And so what we decided to do in collaboration with the team at Primaries is that any pediatric patient that is coming directly from the scene will go to Primary Children's ED first. And we have a protocol for them to collaborate with the Burn Center, and we will come over and we'll chat with their physicians and their trauma team and decide whether the pediatric patient's largest priority is trauma management or burn management. And then from there, we'll decide where the patient goes, whether it's up to the ICU at Primary Children's for trauma management, or whether they come over across the bridge to the Burn Center for burn patient management. So it's a great partnership, and we've done, I think, maybe 5 patients to date that has happened to. And of course, we're always loop closing and working out any kinks in that system. But for those of you that are new to this information, I wanted to introduce that to you right up front so that you know if you are called to the scene of a patient in one of these cases will be scene management. That will be a direct admit to somewhere, maybe primary children's, whichever you decide when we come to that case. But that is the new protocol for our state. The other thing that I wanted to ask you, and hopefully this will get kind of everybody talking or chatting, but I wanted to ask what you want, because that's really important. I wrote down what I thought was important. I wrote down, what in chart audits say are important and what evidence states is important. But what is it that you want in this part the outdoors? And you can chat or you can go on speaker on mic. Did anyone think of anything that they particularly would like to know? All right, well, think about it. The other thing about me is that I'm pretty informal. Don't be afraid to jump in, to interrupt, to squirrel a little bit so that we can have a dialogue about these patients that we're going to talk about. All right, so I decided to start with really kind of the demographics for you in the field. So what kind of pediatric patients are you most likely to see? And here's why I love to work burn, because you can see that many of our patients are younger. So if we're looking at this pediatric subset, so under the age of 18 would be that pediatric subset, then you can see that most of the patients that we see are male. So you are more likely to encounter a pediatric male than a pediatric female. And those folks are typically over the age of 5 and under the age of 16. And that's really, really important, because anyone under the age of 5 is typically more likely to be scald injured, and we see that in the data. And anyone over the age of 5 is more likely to have an injury via flame. And those are some of the things that we're going to concentrate on today, because those are typically the injuries that are sustained outdoors.
Hey, Annette, we did get a chat that said recommended treatment for serious burns when you are in a remote location like camping.
Oh, I love whoever. So Steve, dang it, that is the very first scenario. So I'm gonna actually write this on a sticky note because I've got unlimited sticky notes. So austere care, right? Austere care. Steve, are you search and rescue by any chance? Sweet, all right. That's perfect. Then we'll talk a little bit about that too in this scenario, because this is actually, or the first scenario could be austere, could be backyard, but we see both of those. So we'll absolutely talk about austere care. Thank you for asking that question. So I pulled actually some pretty recent data. We don't have our April data back yet, but I do have March data, and we can see that if we look at the etiology of our injuries that come through our outpatient, we only have 8 flame burns. Typically, we see a lot of scald injuries. Again, those are usually under the age of 5. And we've actually had a lot of contact injury from touching hot objects, but that's because we're still kind of confined to the indoors. But summer will bring an increase in those flame injuries as we move into the future. But that was our data from last month. And so I wanted, as I have an opportunity to have an audience here, to kind of just throw in a public service announcement in regards to the time required to obtain partial thickness injuries. As I came by Starbucks this morning, I saw a ton of people with hot, tasty beverages. But remember, that beverage is about 180 degrees, which can cause a burn injury in a couple of seconds. And this weekend, while I was out and about downtown and kind of looking around, I saw a couple of people with their child and a hot, tasty beverage, one in one hand and one in the other. So just a reminder of the time it takes to obtain a partial thickness burn from scalding water or beverage or soup or whatever it is. We did during COVID, and I guess we still are in the pandemic, but saw a really big increase as people remained at home, and there was an increase in scald injuries, specifically in the outpatient area. So if we think about this data, then we can see that pediatrics with large burns are very low frequency, but also very high risk. And so to go to Steve's question, we're about to get into case one, but I first of all wanted to give you some information that is pretty relevant, I think, to our EMS compadres, and that is the utilization of the BOW score that we use in the burn center. And the BOW score, for those of you that don't know, is defined as the sum of the patient in years plus the percent of body injury. And we're going to do some percentages and we're going to do some calculations upcoming, but it predicts morbidity and mortality of the patient. So that's important because when you run onto the scene of this first patient, then if you take a look at the total body surface area and you add the age of the patient, it's a predictor of how well that patient is going to do. And so there's a couple of cases in here, one's bigger than the others, but you can see that the bigger the burn and the older the person, the more chance this BOW score has of being over 100, which is a very high morbidity and mortality for the patients. And the younger the patient is, and the lower that BOW score, then the better it is that those patients do. And again, this is some data that I just pulled from our own unit, and you can see that it matches that national burn registry data of more males than females. Actually, it was several months ago, but females started to creep up on males, and it was almost 50-50 for the first time that I've ever seen in 31 years, but it's back with a higher percentage of male now. So let's talk about initial evaluation essentials. And remember, what's key here is the standard principles of trauma management. And for those of you that are fire department folks up there, I put this awesome picture of a fireman trying to put out a fire. So let's take a look at this first case study. So this is a campfire. So this goes back to Steve's. I'm in the middle of nowhere and I'm camping. This particular case was in the middle of nowhere, but we have had several cases, especially within the last 8 months, that have actually been in their own backyard. So this could be austere, or it could be urban, or it could be rural. The scenario and the care for the patient is usually always the same. So we've got this 9-year-old male who's standing too close to a campfire, and his PJ is caught on fire. So, I love fire. That's probably one of the reasons why I have been in the burn unit for so long. And I get really close to a fire when it's on, but I'm now much more cognizant of my location and what I'm doing. I know the people around the fire, and 9-year-olds, again, they love to be by that hot heat environment. So his PJs catch on fire. Mom is right there in this particular case, and grabs him and rolls him on the ground and uses dirt to put out the fire. The burn time was very, very short, but that's not always the case. We actually see some people that, especially teenagers, especially if gasoline is involved, and they're throwing gasoline on the fire after watching adults do it, but then the fumes are on their clothes and the fire kind of bounces back, and it makes it very difficult to put that fire out, especially if gasoline is involved. But in this particular case, that is not what happened. The mom dives on the patient, she pushed the patient out. It's a really short fire time. And when you arrive on scene, you're dispatched out to scene. And when you arrive on scene, the patient is very anxious and is complaining of pain. So let's take a look at this form right here. I did a couple of different case scenarios in a couple of different ways, and I'd like you to tell me which one works the best. So we have a primary survey here, which is your standard principles of trauma management, right? And then this is a paper picture of an actual patient and the injury that they sustained. So we've got, you can see there's a little burn on the face, and then you can see the other areas in the picture. You can, if you take a look at our coloring, the red is 3rd degree, the blue is 2nd degree, and we're going to look at what that looks like in a minute so that you guys have a review of what those injuries in your head would look like as you are walking onto the scene of this patient. So the airway is patent. There's a couple of blisters around the external nares. There's no soot or edema in the mouth. Remember, this patient was on fire for a really short period of time. You're listening to the breath sounds in your primary survey. Your breath sounds are clear and they're present bilaterally. So you hear breath sounds on both sides. Circulation wise, your patient has normal sinus tach. Your pulses are palpable in all extremities, moving all extremities. Your patient is crying, but appropriate. And then when you take away the blanket that the patient is wrapped in, then a bunch of blisters and skin sloughs off. And the patient starts to shiver. So this is what I kind of want you to envision in your mind as we're thinking about this patient. You're going to see this slide multiple times. So let's take a look at that depth of injury. So we talked about the blue is second degree, and you can see there's the picture again right at the very bottom. So this patient has a lot of blue or a lot of second degree, which are these two pictures up in top. So you've either got your intact blisters or you've got your skin hanging off. There's fluid oozing everywhere as you've got that capillary separation and that leakage of fluid. And there are some areas that are deeper and they may kind of be not so drippy, not so blistery, and they maybe have a variance in color. And then the deep areas, the areas that are third degree, are going to be non-elastic, right? So you can see that there's areas around both legs that are that way and are burned pretty deeply. And then that picture all the way to the left is a reminder that we do not count first degree burns into our total body surface area. So anywhere that skin is still intact is not counted. So this picture is only second and third degree. So let's take a look right here if we go with our primary survey. So you've got injuries to bilateral legs, to the buttocks, to the bilateral forearms, to your abdomen, to your hair, to your nose, and to your mouth a little. Your initial vital signs are a heart rate of 98. Your blood pressure is 117/66. You've got a respiratory rate of 24. Your SATs are 97. You can't get a temp right now. Your pain score is super high. Your GCS is 15 and your weight is around 24 kilos. So let's go to this very first question and we'll see if you guys can answer this. So is the child in need of airway protection right now? What are your thoughts around that? And you can chat or you can yell out, but do you need to do anything with the airway right now for this child? Screaming and yelling at you.
Remember, just unmute. It's super easy. It's a button click. But we do have a no and a no, not right now in the chat.
Sweet. So Jamie would be right? The GCS is 15. And so right now, we don't need to do anything with the airway and the breathing, so A's and B's on this patient, right? However, let's take a look and see what kind of injury this is. Remember, there are 3 kinds of airway injury. There's your carbon monoxide. So this is your patient that's been found down. They may be responsive still, or they may not be responsive as a result of being caught in a high CO environment. And that treatment is with 100% non-rebreather for about 3 hours. We don't usually put these folks in a hyperbaric chamber, not if they have a burn injury. If they're just CO, then they might go in a chamber. We have our lower airway injury. So the patient has been caught for a long period of time breathing in that smoke and has a lower airway injury or an inhalation injury. That's a true injury. But this is a patient that was on fire, and you can see that in that picture there's a lot of body part that was on fire. So the flames are coming up, and this patient is probably breathing in some of those fumes, right? Because he's on fire. But mom, remember, she jumped on him right away. So there's about 6 to 8 second time frame. So, but there still is an upper airway injury. So that airway above the glottis, and that is caused by direct flame to this patient, right? And remember, he had some kind of blistering around his nares, and And that does not necessarily warrant intubation, and that is really important. Especially, Steve, in your particular case, if you're in the middle of nowhere and you're going on to help this patient and to manage this patient, the last thing that you really want to do from the field is to intubate this patient and then have to bag him all the way out. You especially if you're a BLS crew, maybe you'll have to rendezvous with an ALS crew down the road. But this patient right now does not need to be tubed, but these are still considerations to think through. Because if we think about, initial airway swelling, then we've got a patient at 1 hour. So Steve, let's just take your case scenario. And actually, this was a case scenario of this particular patient. He was hours from nowhere. And so what they had to do was rendezvous with a BLS crew and then rendezvous with an ALS crew, and then take this patient to a definitive care site, but then transported that patient to the burn center. So you can remember the patient did have some facial swelling, and he does have a pretty significant injury, and you're going to tell me how much in a minute. But remember, it takes a while for that swelling to occur. It doesn't usually happen right away. So these patients do well initially. And so you have got some time, but 6 hours down the line, then it doesn't mean that this patient won't need to be intubated. In fact, if you take a look at this patient who also sustained an upper airway injury, you can see that had this patient not been intubated, then he would have gotten in trouble, right? This would be a dead patient or somebody that would need an emergency cric. So this is 1 hour post-injury. So Steve, let's just, again, I'm using you as an example. So you get dispatched to the middle of nowhere, you get on your ATV, or you get in your ambulance, or you get whatever it is that you use for your rescue truck. What do you use, Steve? For search and rescue response. So it could be a Jeep or a four-wheeler, great. So you've got minimal resources, right? So you get in and you get to this patient and you perform BLS. And Steve, you will be just fine performing BLS on this particular patient, right? So you know that, well, we don't know yet, but we'll continue on with the case, but you're going to try and keep that airway stable. So you're going to sit the patient up, and so that their edema formation kind of all drops down, and keep that patient up in your Jeep or four-wheeler and just keep talking to that patient, and then maybe rendezvous with an ALS crew outside of there at a landing zone or something. And that is exactly what happened to this patient. But you've got a limited time period in order to get assistance. So you may say to the crew that is rendezvousing with you, hey, we've got a patient, they've got some burns on their face. I'm a little worried about them. They seem to be a larger burn injury, and provide them with that information so that they can bring or be ready for whatever it is that you will need. Is it mostly the inhalation of hot gas or the fumes themselves that causes the inflammation? That's a great question. So if this patient were in a high heat environment, or there were to have been an explosion, so let's just say a natural gas explosion with that blast wave that comes back on the patient, then or even just a teenager that's messing around with gasoline, and then there's kind of a fast flash, and the patient goes right in this high heat environment. So now they have an oral pharyngeal injury. And that causes a burn injury of just that oral pharyngeal area. And this patient may have a little of that also, although it wasn't kind of that enclosed space kind of fast flash. Or a carburetor is another one, when there's an explosion from the carburetor. There's usually an older person that gets that. It's a high steam environment. So, but what that does is it causes that inflammatory response and a separation of those capillaries, and that edema formation begins to occur. And And the airway is about the size of a pinky. So this patient has a really small airway. The 9-year-old that we're talking about has a bigger airway, but the inflammation is actually caused by that inflammatory response. And the larger the burn, the larger the inflammatory response. And so if I have a burn to 9% of my body, which would be just this arm, or this patient, 9% of their arm, they will only swell usually in that smaller area, but 20% burns trigger a full body inflammatory response. So in this particular patient's case, he has a pretty big burn, and you guys are going to help me calculate his total body surface area of injury. So dependent on his TBSA, he may or may not have this full body inflammatory response. And even though he just has a small area around his nasal, kind of around his nose and around his mouth that has sustained some burn injury, he still may be at risk down the line of swelling and occluding his trachea. So that's a great question.
Hey, Annette, I have one more question on that, if you have a second.
Yeah, you bet, Jimmy.
Does age have any impact on that inflammatory response or time frame to the inflammatory response? As we see, this little kiddo swells, a lot. As they get older, does that lessen, or does that really not have any impact at all?
No, that's a great question, Jamie. So we know from evidence that the very young and the very old don't do very well because of that traumatic response, whether it be burn injury or whether it be a trauma. So the extremes of age just don't do well because they don't have that resiliency. And then we also know that the size of the trachea matters, right? So my trachea is, the size of my pinky. So I have a little more reserve than this pediatric patient who, like a swelling of about an inch diameter around my entire tracheal area. I'll still have an open trachea, but this little guy may not. So we have less tolerance for observation of an airway in a pediatric patient because their occlusion, just by the sheer nature and the size of their trachea, that occlusion occurs more quickly. So we would be more likely to intubate a pediatric patient than we would an adult. In an adult patient, if you take a look at this picture on the left, you've got those protruding lips and you've got eyes that it's kind of difficult for the patient to open. In a pediatric, we would be fast to intubate that kind of patient because those are the telltale signs for us that we need to monitor the airway and provide support. But an adult, I've seen adults on our unit that have kind of protruding lips and kind of have difficulty opening their eyes, and they are not always intubated, but peds usually are. Does that answer your question, Jimmy?
Yes, thank you.
No problem. All right, so Steve, I'm not sure if you have 100% non-rebreather in your Jeep or on your ATV, but responding crews, this would be one of the priorities, right? So as we're talking about airway and breathing, then giving this patient oxygen would be a priority. Although, what are some of the challenges of a 9-year-old that you can think about related to keeping oxygen on? Oh, nice job, Steve. You do have oxygen. That's great. Susan, you're highlighted. Does that mean you want to say something? Let me put it another way. If I had some burns to my face and I was 9 years old and I was in pain and I was seeing my skin fall off, would I keep oxygen on? It would be really tough, right? So in regards to first responders needing to keep oxygen on these patients, how could you deliver that to them in a way that might be more appealing as opposed to a mask over their face? Angie, nice job. Blow by. Absolutely. And that's what the EMS crew did to this particular child. They had a cup, they had a blow by, the kid sat on mom's knee and mom held it. So the child was still getting the necessary treatment and did really well because of that. So I kind of highlighted hoarseness here because were this child to kind of have that tight kind of hoarse voice, it sounds like they're a lounge singer, but he obviously isn't a lounge singer, you'd be worried. And there's been some case scenarios where patients on scene describe tightness or they're hoarse. And that would be one of the things that should make your sphincter tight, even if the GCS is 15. So that would be something definitely to watch out for as we go through our Is and our Bs. And in the burn perspective, and this is really important, it's going to bring up a point that we've already talked about. When Steve goes out on his ATV or in his Jeep, his biggest concerns with this 9-year-old is the airway open? If it's not, obviously that's a problem. Can the patient protect their airway? If they can't, that's a problem. This kid is yelling and screaming. His pain score is 10 of 10. He's crying, he's anxious. His favorite blanket now has skin all over it. And he's shivering, he's scared. So can they protect their airway? And I would say that if your patient is still talking and crying, then you can relax a little bit because you know their airway is okay. Is inhalation injury suspected? This particular kid, it wasn't, right? He was outdoors in an open environment. He was on fire for a short period of time. It wasn't like he was running around on fire like some of our patients are for a prolonged period of time, breathing in that smoke. Does the patient have facial injuries and edema? This kid does have facial injuries, but as of now, he does not have any edema formation. And is the burn larger than 20%? And this goes back to, let me see whose question it was. Steve's question about inflammation. So remember, we talked about bigger burns trigger that massive inflammatory response that even if they don't have a facial injury, we worry about the airway occluding. That is this category right here. So if the patient's burn is greater than 20%, then those are the patients that we recommend intubation. Now, it doesn't mean right away, but if you're a BLS crew and you're responding, then you might be calling into your ALS rendezvous, or if you're 7 minutes maybe from a local definitive care site, then you're saying this is a big burn, it's over 20%, you might want to have airway equipment ready. So these are the things that should be going through your mind. You have time, but that might be something that would be recommended in the future. Any questions on Is and Bs on the need for airway protection? All right, so where will you place the IV and how fast would you start the initial fluid? So there was a new fluid formula came out in 2011, 2012. So it's been around for a little while. And there were some nuances for this kid around placement. But if this were you and you're looking at this 9-year-old that's in the picture right there, where are you going to start the IVs and how fast are you going to do it? This, remember, we're still in our primary survey. There's no wrong answers.
Well, it looks like he only has one elbow available. So I'd probably try the elbow first. It's not burned. But it looks like there's a tiny space around the one knee. So if he was unconscious, you could probably do one in his knee.
And there we go. That's great, Charlotte. Yeah, those are great suggestions in going or trying primarily to go in a non-burned area. That's really great. That definitely is recommended. So if you have a non-burned area that you can get an IV in, then that is great. But the reality is, if you don't have a non-burned area and the only thing that you have is a burned area, you can go right through burned tissue. It's clean, right? So it's kind of like the patient's been through an autoclave, so you can go right through that burned tissue. The problem for you guys in the field is securement. because if you go through burn tissue, then it's weepy and it's oozy, and so it's difficult to stabilize that IV and keep it in place, so it can be lost easily. And then we want to give consideration for that swelling, that inflammatory response that's going to occur that we talked about. So wrapping it tightly in Coban is tough too, because Coban doesn't stretch, and so it can occlude pulses eventually. But checking it is a really good idea if that's all you have. Wrapping it in Curlex is a great idea too, because Curlex expands a little bit in order to keep that IV in place. We've got an IO suggestion by Amber right there in the chat, and that is great also. So on this kid, they couldn't get an IV in him initially. Now, it was really tough. The BLS crew was at least 30 minutes out after parents had to go to an area where they could get cell coverage, because they were literally in the middle of nowhere. So they had to drive to get cell phone coverage. They rendezvoused with the BLS crew. The BLS could not get an IV because the kid was super clamped down. And in that situation, Amber, an IO would have been a really great solution to that, because it's a really good line. So if you can't get an IV in through unburned tissue, that would be your first preference. If you can't get an IV in through burned tissue, would be your second. Then an IO through burned or non-burned tissue. So you can put an IO through burned tissue also. That's a really, really good response. Any other questions or suggestions related to placement of an IV and how fast you would start it? Any guesses on how fast is recommended for this 9-year-old?
Hey, Annette, just a weird question from my own knowledge. Can you see veins through burned tissue?
So it depends. And it can depend on the depth of injury. So there's been patients, especially a patient that I really remember, who went into a hot pot up in Yellowstone, and you can see coagulated vessels on a really, really deep injury. So you can see actually those vessels through the burned tissue on some of those patients, but most of the time, it's not like I can put a tourniquet on and get kind of a really good line like I would be able to see on myself. But placement, like the patho, the VINs don't switch location. So you can kind of put a tourniquet around it and see if you can feel it, and then go for it in that regard. So it will still kind of pop if your patient hasn't gotten hypovolemic, so has an extended time out after injury. So you can still see it pop, but you may not be able to visualize it as well like you can on non-burned tissue. But it's very rare, to be honest with you. And this was one of the few that I remember in 31 years that a patient they were unable to get an IV on any patient. Usually the EMS hit those vessels right away and do a fabulous job. In fact, oftentimes they'll put 2 in. So, and then we're getting Jamie humeral head IO and start IV as soon as possible for fluid management and pain control if possible. So any of those options that all of you mentioned are great. All that matters is that you get an IV in this patient, because this is why. So remember, fluid resuscitation is the primary objective of initial burn treatment, right? So I think of this in regards to trauma. So you've got a trauma patient with let's just say they're hemorrhaging everywhere. And the fix for that is you put your finger in the dike and you stop that hemorrhage, or you apply a cat and you tourniquet that off and you stop the bleed, right? That's what the class is all about. You stop the bleed and you save a patient. But in a burn patient, those capillaries separate and there's this massive leak of fluid, particularly in this patient with a larger burn injury. And there's no putting your finger in the dike on this patient. The fix is to give the evidence-based fluid that is appropriate for the management of this patient. And here's the formula right here. So this patient is 9 years old. So you can see in the primary survey, the starting rate is 250. So you would insert your IV or your IO, whichever it is that you can get in through burned or non-burned, or through an IV or through an IO. It doesn't matter. But in your primary survey, that is not a place to estimate total body surface area of injury, right? Your primary survey is just a place for you to say, hey, this 9-year-old is going to live or die. And if you establish in your primary survey, so your ABCDE section of your ATLS, your survey, that this patient isn't doing well, then you fix whatever it is in your primary survey before you go on. So this isn't the place to calculate total body surface area or a place to do any kind of fluid calculation. And that is why there's a set start rate in the primary survey. So this 9-year-old would get that IV in and would get a fluid rate of 250. It's the secondary survey that we would go on to establish what rate of fluid this patient would require. And I know that there are probably a bunch of you out there that only have NS on your rigs. We're starting to see a lot more LR come into play, especially for first responders. But it doesn't matter what you have. We like lactated ringers because it actually looks a lot like extracellular fluid, and that's where all the fluid's going to leak to, right? Whereas normal saline has a high sodium and a high chloride. So after a ton of fluid, like 7, 8, 9 liters, it can switch your patient's pH. But for you guys with a short response time, so if it's urban, you're usually looking about 7 to 10 minutes. If you're rural, then you're looking at an extended time period. But it doesn't matter. You shouldn't be giving a ton of fluid prior to the patient reaching a definitive care site, wherever that definitive care site. Although, Steve, if that's what you have and you're truly in the middle of nowhere and nobody can rendezvous with you, you may go through 4 or 5 liters. But it's unlikely that you're likely to get up to 8, 9, 10 liters of sodium on a patient, unless that patient has a super, super big burn. And Steve's saying we'd likely call a helicopter. That's perfect. So let's go on to question number 3. So could there be any of the emergent problems? So we've got this kid around a campfire. We've got this mom barreling into him, knocking him over, covering him in dirt as she tries to put out her screaming 9-year-old that's on fire. Could there be another problem?
Is mom burned?
She's not. Well, clothing was a little ruffled, but not burn injured.
Well, he's totally contaminated now from rolling in the dirt.
Charlotte, I love that you said that, because that does come into play on this patient, although we don't really necessarily address it in this case study because this is scene responder. But I love that you brought that up, because remember, your skin is a barrier and a form of protection, right? So anytime you have a patient that's in, especially the environment with all these gram-positives and gram-negative bugs everywhere, and mold and spores, and if they're jumping into the nearest lake to put themselves out, now you've got the contaminants in that lake. So we're worried when those patients come in that there's a level of contamination of bacteria, and that is what happened to this patient, Charlotte. I mean, thank goodness the mom put the patient out, but we do worry about what's in the dirt, and sometimes that does come into play for our patients. So think about that in the background too. This could be a patient that is with us on the unit for a very long time, related to the infectious process that occurs from the soil that they're put out with. So that's absolutely something. Anything else that you worry about? All right. So here's a thing. If this patient is not tachycardic, because he's 9 years old, right? It's highly unlikely he's taking a beta blocker. It's highly unlikely that he's been at a rave before he was at the campfire and taking rave drugs that also affect your vital signs, right? But think about that. If you're responding to anything at Saltaire or some local party or some teenage underground event, right? Because normal vital signs are really important. this kid will be tachycardic, right? Because he's just gone into fight flight. He's burn injured. His mom dived on him. She put him out. He has this massive inflammatory response and this massive catecholamine release. Every burn patient you see should be tachycardic, right? They should be, unless they're older and they're on medications, but our pediatric population usually is not, so that they should always be tachycardic. Their blood pressure should always be normal or hypertensive. If you come on scene and you're seeing a kid with a low blood pressure and they're not tachycardic, or there's just a low blood pressure and they are tachycardic, there's a problem. And the problem is not the burn, right? The problem is an associated injury. So always consider the chance for associated injuries. And that's actually one of the reasons we collaborated with Primary Children's, because their emergency department is very used to seeing pediatric associated injuries. And so we want to ensure that that is picked up on. But as a responder to this chaotic scene, don't forget what your vital signs on a burn patient should be. And they should always be tachycardic. They should always be hypertensive. But the caveat here, because remember, you know, when we talked about placement of an IV, we've got circumferential injuries on this patient, right? Now, they're not circumferential arm injuries, but if you're taking a blood pressure on a patient with circumferential injuries, it could be inaccurate. So consider that. But these patients are always alert, awake, and oriented, and this patient was no exception. So let's take a look at our secondary survey. So we're finished with our primary, right? We've established the patient doesn't need an airway. We've got an IV in, we're running it at 250 because that's recommended. We've established so far that there's no associated injury on this patient. At least it's going to kill him right now. Our vitals are good. And so we're going to move on. So in secondary survey is our head to toe of this patient, right? So patient no allergies, a history of constipation, ate a typical kids meal, chips and a soda. We've got our pupils are equal and reactive with no problems on our head to toe. And then our repeat vitals, heart rate of 91, blood pressure of 118/61, respiratory rate of 18, SATs are 97 and temperatures 36.8. So what is the total body surface area of injury on this patient? Let's take a look at this patient. So what is our TBSA? Let's go with, are they above 20% or are they below 20%? What do you guys think? Above. Yay, yes, they're above 20%, right? Because we talked a lot about it, and you can see this is a pretty big burn, but know that this is really difficult for you guys to do, especially before the patient's debrided, right? And so you're getting a ballpark, but what's really important is that you either use the rule of nines or you use the rule of palms. And the palm is the patient's hand, inclusive of their fingers, equals 1% of their body. So if this 9-year-old's hand fit twice into mine, 2, 4, 6 on that patient, right? And we're just looking for a ballpark, but we're wanting to start fluid on this patient, and we can't start fluid, at least not evidence-based fluid, without an estimation of the TBSA, because that is what we use to get the fluid formula. So how would you determine fluid requirements for this patient? You can put it in the chat, you can yell it out. What is the burn formula, the consensus formula, or Parkland or Baxter? It's actually called the consensus now, but it's been called Parkland for a long time. It's because of where it originated. There's a Baxter formula too, and those two formulas kind of came together, and now we call it the consensus, which is 2 to 4 mils. But specific to pediatrics, there's a pediatric start mil. Anyone want to take a guess on that? All right, let's take a look at it. So the consensus formula is 2 to 4 mils times the total body surface area of injury, which we established is over 20%, times the patient weight in kilos. And we want to give half of that over the first 8 hours, which was the time of injury. And then we want to divide that by 8 for an hourly rate. And we're going to do this math in a minute. And then remember, pediatrics are 3 mils. Adults are 2 times the weight in kilos times the TBSA. And then deep tissue, so like a crushing injury or an electrical injury is most common, would be 4 mils. So let's do that calculation together. So we've got 3 mils for a pediatric patient, times this patient was actually 28.5. He was a big burn and he was 24 kilos. So that gives 2052 mils, right? Over that 24-hour period. We want to give half of that in the first 8 hours. So we're left at 1026 mils. And then we want an hourly rate. So we divide that by 8. And that gives us about 128 mils an hour. But remember, we started this patient in the primary survey at 250. So we're going to lower the rate. Now we've established an evidence-based rate to start this patient off at. And that's really important. And I know we're coming short on time, so we may not get to one of the end slides, but what I put in that end slide is when I do chart audits, too much fluid continues to be given, and that can cause some compromise in our patients, and they don't do well as a result of that. They don't do well as too much fluid and too little fluid. So does it really matter, right? Yes, it does. Patients can require escharotomies because that fluid, remember, they have that inflammatory response and it moves out of the capillaries and it drags more fluid with it. So they actually require greater amounts of fluid if they're given too much fluid up front. Can cause abdominal compartment syndrome, as evidenced by that lower left. And it can cause more swelling. So a patient might need to be tubed when they didn't originally need to be intubated because of that additional swelling that occurs. And it also causes problems in the lungs, especially with pediatrics, with that movement of fluid into the lung. But too little, obviously, is bad too. It results in organ failure and kidney injury. So we don't want that to happen. So how would you provide pain relief on this patient?
Hey, Annette, really quick, I know we are pressed for time, but what would you suggest for, because this has been a problem in EMS, getting the right fluids, and the practice has kind of been to just throw up a 500 cc bag and get it running. Should they be contacting medical control? Is the Parkland something they should be figuring out on their own? What tool do they have to help them with this calculation? Because no one wants to do math in the field.
That is true. And I love, Tia, that you brought this up. So the initial start rate, remember the primary survey start rate is set. That has been set by the American Burn Association, so it's a national standard. So in your primary survey, that's what the fluid rate should be started at. And if that's not in your current protocols, then you can go back to your medical control and talk about that. I'd be absolutely delighted to talk to any of them about it and send evidence. The other website that might be helpful for you guys to go in, and I'm also happy to send you pocket guides with all pre-calculated information on too, but we have a website. If you Google crisisstandardsofcare.utah.edu and request access. So crisis standards of care is all one word, .utah.edu. And it's a request access site, but I'll let you in. And then on that site are all kinds of pre-calculated fluid rates. And we've got these little books. I know you're not sure if you can see it, but they're kind of pockets. But they have pre-calculated fluid rates on so that you don't have to stop and do math in the field. But the math that we just did is pretty simple. And I love, to Tia's point, the patient doesn't not do well in the field, right? So you guys are doing the best you can in a chaotic environment, but I have seen patients given their entire 8 hours worth of fluid in the first couple of hours. And that is detrimental to long-term outcomes because care in the field significantly impacts the long-term outcome of the patient. So this fluid the fluid calculations are really imperative. And if you know your patient's doing well and you've gone through your primary and you're not worried about airway or deficits, then there's time in the secondary to do perhaps a little bit of math or get pre-calculated charts and adjust the fluid. So that's really, really important. Did that answer your question, Tia? Is there anyone else that has other questions related to that? And again, I'm super happy to talk to anyone. I'm sure happy to put, if Tia can put my email address in there and you guys can snap a picture of it, but happy to chat with anyone about that. So what would you do? Because I guess we've only got time for really one case, huh? We're not going to get to fireworks or to inhalation, but what are you going to do to provide pain relief for this patient? Steve, what are you going to do when you go into that austere environment? You've got your IV in, what do you have? Steve, I love that you wrote that. So no, Steve, and I'm going to actually flip to this next slide because I highlighted alternative techniques. So Steve, whilst you might not be able to give narcotics to this patient, telling the patient and their loved one about why they hurt is really important. You've got exposed nerve endings, and so let's cover them up. Let's put some dry Curlex on so we can relieve the pain. When you pick the patient up, cradle them as opposed to grab them around their burn injury. That helps. Lifting their arms or legs, whichever is burned, to around heart level will also diminish the pain. And covering it with something, whether it be Curlex or a blanket or anything, it doesn't matter. It will stop the air from getting to it. So that will decrease the pain load. And then it will also stop the patient from being so anxious by seeing their burn injuries. So you actually, Steve, can do a ton without the use of narcotics, which is really important. And if you're going to give narcotics, if there's ALS crews that are listening in, small amounts frequently are key, because you don't want now a patient that's screaming and yelling, and then all of a sudden the patient's not screaming and yelling, because that's not always a good thing, right? We want an airway, we want a breathing child, and you'll never, ever be able to take all the pain away. You won't. You'll just be able to take that edge off it. So aiming to take the pain away is we can't even do that on our unit. So not something that can be done in the field. I know we're already a little over. Tia, tell me how long I've got left. I'm almost done with this scenario. Do you want me to finish up, or do you want me to?
Go ahead and finish this case. Anyone who needs to leave can go. And then I'm going to have to book you for a part 3 because I want to see the rest of the cases.
I had some really good fireworks. Oh, well, we'll do it again. So how would you dress the injuries? We talked a little bit about this already. What would you put on this patient? Does it matter? It actually doesn't matter. If you've got Curlex, wrap the patient in dries so they don't see it, especially if it's a longer trip in. But if you just throw a blanket over the patient, that's totally fine. Or Mylar blanket to stop the patient from wetting the blanket that's also covering them, so then they won't lose more heat via evaporation. So you can dress or you can not dress. All that matters is that you don't put topicals on this patient and you don't put wets. Got to keep that patient warm and dry so that they don't get hypothermic. And then, does the patient meet criteria for referral to a burn center? So let's loop all the way back to the beginning of this conversation, in which we said that a patient coming as a direct admit from the field, because Steve is out, he's BLS on this patient in the middle of nowhere. They rendezvoused with an ALS crew who's going to helicopter them in. So this patient is going to come in from the field. So he's going to hit primary children's ED. He's going to have a workup in the ED. Our burn team will meet the team at primaries over in primary children's ED. So does the patient meet criteria for burn center referral? Absolutely, right? This is a really big burn, but this particular patient, because of the etiology severity of injury. And because he's coming directly from the scene, now if this patient were to hit an outside hospital first and to have a trauma workup at an outside hospital and then be transported to the burn center, he's going to come directly to us and not need to go to primaries. But if he's a scene transport, then that is where this patient is going to go. And we know that he's got a big burn, so he meets a lot of this criteria, right? He's a big burn, it's over joints, he's got some 3rd degree, he's in extreme of age, and he didn't have trauma, and he's got circumferential injuries. So that is where he's going to go. And when you're transporting this patient, all that really matters is you watch his airway, right? You've established he doesn't need to be intubated right now, so Steve is okay, rendezvousing on the way in. Fluid formulas are really important, keeping the patient warm and dry, not getting distracted by the very thing that won't kill the patient is really important. And the thing that won't kill the patient, not initially, is the burn. Ensuring that you educate the patient about why they hurt, why they have pain, that you cover their wounds so they can't see them, so they're not getting really anxious, and that again elevates their pain score. You really just, you ride your bike, right? Even if you have never taken care of a burn patient before, as long as you adhere to your standard principles of trauma management, which is your primary and your secondary survey, and you don't deviate from that, you will do just fine with these patients. And so I guess we'll relay the next 40 slides or so. We'll have to come back and do this more often. But thank you guys for joining us. Again, I can't thank you enough for the work that you do in the field. You really do a great job. You know, like we talked about earlier, it is extremely rare that we see somebody coming in without fluid. It is extremely rare that we don't see just the best care delivered by you guys that are out there with minimal resources, sometimes in the middle of nowhere, like Steve, in an austere environment. But thank you for all you do.
Thank you so much, Annette. She is always fantastic, and I will book her. We have still got a few open slots for this year, so just be prepared for that email, Annette. Make sure that you've got your email address in the chat, because I'll be sending out the certificates this afternoon. And come on, this is the easiest CME ever, and it's such good, fantastic information. So thanks for joining us, everyone. I'll stick around for a few minutes to let you add anything to the chat.